Well, hello and welcome to my diagnosis series. This is the first uh, video in the series, um, and this one will be on the DSM-5 diagnosis for the pathology in the family courts. Now, throughout healthcare, diagnosis guides treatment. The treatment for cancer is different than the treatment for diabetes. And so we must first diagnose what the pathology is before we know how to treat it. Means the same thing as we must first identify what the problem is before we know how to fix it. So these terms mean the same thing. Diagnose means identify, pathology means problem, and treatment means fix it. So in the family courts, the parents and children in the family courts have a problem. We need to diagnose or identify what's causing the problem so that we can fix the problem, whatever that problem may be. Now, in terms of ethical standards, Standard 2.04 of the Ethics Code for the American Psychological Association requires the application of the established scientific and professional knowledge of the discipline as the bases for professional judgments. And the DSM-5 from the American Psychiatric Association represents the established scientific and professional knowledge of the discipline that's required for application as the basis for diagnostic formulations and professional judgments. Now, we can add additional applied knowledge from attachment and family systems and personality pathology and complex trauma. All of these additional domains of knowledge can also be used in developing diagnostic formulations and for treatment-related decision makings. And the established scientific and professional knowledge of the DSM-5 diagnostic system from the American Psychiatric Association should always be applied as a foundation for diagnostic formulations and professional judgments. And so there's several reasons why it's important to apply the established knowledge of the DSM-5. And people may disagree with, DSM and its categories and things. At the same time, though, it provides a baseline of professional knowledge that's applied for things like schizophrenia, bipolar disorder, delusional thought disorders, factitious disorders. It defines a scope of pathology that's been established in the research literature. And it also allows for a professional level discussion among the other professionals involved so that all the doctors know exactly what diagnosis, what identification of the problem is at a professional level. So while the mental health people can apply additional established knowledge, such as from attachment, family systems, complex trauma, personality disorders, all will broaden and inform the diagnosis. At the same time, the DSM-5 diagnostic system should be applied all the time, consistently, as the bases for diagnostic formulations and professional judgments. Now, throughout healthcare, the typical approach to diagnosis is called a differential diagnosis. So this is from a paper, Improving Diagnosis in Healthcare, from the National Academies of Science, Engineering, and Medicine. And they indicate that in describing the diagnostic process, that the working diagnosis may be either a list of potential diagnoses, a differential diagnosis, or a single potential diagnosis. Typically, clinicians will consider more than one diagnostic hypothesis or possibility as an explanation for the patient's symptoms and will refine this list as further information is obtained in the diagnostic process. So that's a differential diagnosis. We start with the symptoms and we apply all of the potential explanations for that set of symptoms. And then as we gather more information, we rule out some of those explanations and others are supported. And that's the process by which we make a differential diagnosis. So in terms of the diagnosis of attachment pathology in the family courts, the only cause of severe attachment pathology, a child rejecting a parent, is child abuse by one parent or the other. Less severe forms of problematic parenting produce what's called an insecure attachment that more strongly motivates the child to bond to the parent. If we have a child seeking to flee a parent that's rejecting a parent, the only cause of that would be abusive range parenting from one parent or the other. So either the targeted parent is abusing the child in some way, thereby creating the child's attachment pathology towards that parent, or the allied parent is psychologically abusing the child by creating a shared or induced persecutory delusion and false factitious attachment pathology in the child for secondary gain to the allied parent. So the differential diagnoses in the family courts, there it is either the targeted parent is physically, sexually, or neglectfully or psychologically abusing the child, creating an authentic attachment pathology due to the child abuse, or the allied parent is creating a false or factitious attachment pathology and is creating a delusional disorder in the child, persecutory type. There's the DSM code 297.1. A false or a factitious attachment pathology imposed on the child for secondary gain to the allied parent, DSM 300.19, and that either one or both of those producing a persecutory thought disorder in the child that destroys the child's attachment bond to the other parent would represent an additional modifying V code diagnosis of child psychological abuse, as well as the additional V code of spouse or partner abuse of the targeted parent by the allied parent, using the child and the child's symptoms as a spousal abuse weapon, DSM-5 995.82. So in the differential diagnoses for attachment pathology, either we have child abuse by the targeted parent or we have child abuse by the allied parent. And so in all of these cases in the family courts where we have a child rejecting a parent, the mental health people should be returning a diagnosis of child abuse one way or the other. Currently, they're not. And it's of considerable concern that they are not rendering a diagnosis of child abuse when child abuse is the only cause of the symptoms. And so that's why we need greater clarity. Are they properly assessing for the delusional thought disorder? Are they properly assessing for the false or factitious attachment pathology? Are they even considering it? Are they considering the spousal abuse diagnosis of the targeted parent by the allied parent using the child as a weapon? And that's the importance of them making a DSM-5 diagnosis in every case, so that we can evaluate whether or not they are considering these various diagnostic possibilities. If they do not list a diagnosis in their reports and paperwork documentation, then they are indicating by the absence of a DSM-5 diagnosis that there is no diagnosable pathology present. Because if there was child abuse present, they would tell the court, right? And they would tell the parents, and they have duty to protect obligations. If there's spousal abuse, they have duty to protect obligations, and that would be relevant information for the court, that the one parent's using the child as a weapon. Factitious disorder imposed on the child, false attachment, that would be relevant information for the court in making its decisions, as would a persecutory thought disorder in the child created by one of the parents. So all of those diagnoses should be discussed as part of any mental health assessment and report into the court, and it's not being done. And we need to get back to baseline professional standards of practice in professional psychology, starting with the application of the DSM-5 for all diagnostic formulations. We have a differential diagnosis of child abuse by one parent or the other, and we need a proper assessment for the differential diagnoses of concern. So in professional psychology, there are three dangerous pathologies: suicide, homicide, and abuse, child abuse, spousal abuse, and elder abuse. And all mental health professionals have duty to protect obligations, so that whenever a mental health professional encounters a dangerous pathology, that suicide, homicide, or abuse, duty to protect obligations are active. And here's from Wikipedia describing duty to protect. In medical law and medical ethics, the duty to protect is the responsibility of the mental health professional to protect patients and others from foreseeable harm. So whenever a mental health professional encounters a dangerous pathology, suicide, homicide, or abuse, a duty to protect is active, and the professional has three obligations. The first is to personally conduct a risk assessment for the danger involved, or to ensure that a proper risk assessment is conducted. So, for example, if it's a suicide is the danger, then the involved mental health professional must conduct a proper risk assessment for the suicide, or ensure that the person gets maybe to the emergency room and gets a proper assessment there. In addition, the second obligation is that the mental health professional needs to take affirmative protective action based on the danger involved. So they need to do something. So again, for suicide, that might be increasing the number of sessions, to twice a week, or setting up a phone call to check in with the person, activating social support network around the person. So some sort of affirmative protective action must be taken. For homicide, it might be contacting the police, might be contacting the, intended victim under certain circumstances. For abuse, there would be protective actions relative to, referrals into child protective services, and other steps that might be warranted relative to a child abuse risk or spousal abuse risk, helping the parent get into a shelter or something like that. The third obligation of all mental health professionals when we encounter a dangerous pathology is that the protective action we took should be documented in the patient's medical record. So in my background, I served as a clinical director for a 3-university assessment and treatment center for children ages 0 to 5 in foster care. Child Protective Services was our primary referral source. So I'm well familiar with professional obligations around child abuse, and we had interns and postdoctoral fellows at our clinic. And so this would be the obligations. If one of my interns or postdocs or professional staff encountered a dangerous pathology and was seeking a consult, these are the obligations they must do. They must first either conduct a risk assessment or make sure that it gets conducted, that we have to take some sort of protective action, and then document what protective action we took in the medical record. So that should be occurring in all cases of court-involved custody conflict where a child is seeking to escape or flee from a parent, because that would indicate that parent is either abusing the child, creating authentic attachment pathology, in which case we have duty to protect obligations. We need to do a proper assessment and take protective action. Or it's a false, factitious attachment pathology imposed on the child for secondary gain to the allied parent, in which case we have to do a proper assessment of that and take protective action if that's there. And document that for the court, document that in our reports and the medical record for the patient. Now, a failure To conduct a proper risk assessment for a dangerous pathology, suicide, homicide, or abuse, may represent negligent malpractice. So here's from the Cornell Law School, their definition of negligence. Negligence is a failure to behave with a level of care that someone of ordinary prudence would have exercised under the same circumstances. The behavior usually consists of actions, but can also consist of omissions when there is some duty to act. And so the ordinary prudence under the same circumstances would be relative to another mental health professional, relative to a licensed professional when they encounter a dangerous pathology, suicide, homicide, or abuse. So when that's on the table as a possibility, what would a normal doctor of ordinary prudence do? We would conduct a proper assessment or make sure an assessment gets conducted for the danger of suicide, homicide, or abuse. We would take some sort of protective action and we would document that in our chart. And so if that's not occurring, then that would potentially be a negligent failure in duty to protect obligations. So based on the referral pathology of a severe attachment pathology, a child rejecting a parent, child seeking to flee from a parent, multiple possible abuse pathologies are present and duty to protect obligations are active. So there's possible child abuse by the targeted parent, creating the child's attachment pathology towards that parent. There's possible psychological child abuse by the allied parent, creating a shared induced persecutory delusion and false factitious attachment pathology in the child. And there's possible spousal psychological abuse of the targeted parent by the allied parent, using the child as the weapon. So in all court-involved custody conflict involving severe attachment pathology displayed by the child rejecting a parent, a proper risk assessment needs to be conducted to the differential diagnoses for each parent. And there's the differential diagnosis. Either the targeted parent's abusing the child in some way, in which case that's need to be a return diagnosis of child abuse, or the allied parent is creating a delusional thought disorder, persecutory delusion, encapsulated persecutory delusion, and a false, factitious attachment pathology imposed on the child for secondary gain to the allied parent. With either one or both of those would be an additional child psychological abuse diagnosis and an additional spouse or partner abuse psychological diagnosis from the DSM-5. So in all cases of court-involved custody conflict where there's severe attachment pathology, a child rejecting a parent, a proper risk assessment for child abuse and for spousal abuse needs to be conducted to the appropriate differential diagnoses for each parent, and a DSM-5 diagnosis needs to be discussed and returned relative to the family. Now, if there's no discussion of how the delusional thought disorder was assessed, or why it was ruled out or ruled in, or the spousal abuse diagnosis, or all of the relevant diagnoses, if there's no discussion of that, that could potentially be a negligent failure in duty to protect obligations, given the nature of the child's symptoms. And it is extraordinarily concerning to me as a clinical psychologist that the only possible cause of the pathology, the child's symptoms of rejecting a parent, is child abuse range parenting by one parent or the other. It is deeply concerning that the forensic custody evaluators never return a child abuse diagnosis in any case when it's child abuse by one parent or the other. So I would offer that the forensic custody evaluators are failing in their duty to protect, and potentially it's a negligent failure because they're failing to conduct a proper assessment for the pathology involved. And then I would also argue that there's boundaries of competence issues relative to why they're not assessing for delusional thought disorders. They're not competent in doing that. They're not competent in attachment pathology, complex trauma and child abuse, number of different family systems, number of different domains that need to be substantially improved in the quality of professional services. So with that, I'm going to wrap up this first installment, chapter 1 of the diagnoses series, in which I, in this chapter, discuss the DSM-5 diagnoses of the pathology in the family courts.